Dear friends, I think we can start. This is the number 17 of update of spine surgery uh, webinars under the name of International Academy of Spine, Middle East Spine Society, and WFNS Education Committee. Uh, uh, we will have a meeting on management of myelomeningocele. And Graham Fieggen is one of the moderators, uh, and probably he will make the first talk because our friend from Brazil did not join us yet. Yes, Graham.
Great. Thanks, Mehmet. Should I carry on so long?
Yeah, you can.
Okay, great. Let me see if I can pull up my presentation. Fantastic. Is that showing?
Good evening, sir.
Okay, wonderful. Well, so Professor
Krishna,
Zilek,
welcome, but Graham is starting. Okay.
Yeah, sure, sir.
Sergio, hi, Sergio just joined. Okay, you want me to carry on?
Yes.
Fantastic. Okay, well, thank you. Thank you very much for the invitation to be part of. I've seen all of these regular educational events that you've been organizing over the past couple of years, and it's always a pleasure, Mehmet, to be part of your educational contributions. And thank you for inviting me to be part of this. So I was expecting to speak after the talk on prenatal closure. But anyway, let's carry on so long, and then we can hopefully hear from Sergio, who's got a lot of experience in this area, and then Adnan can tell us about the long-term management of these children, which is so rewarding. So the focus of my talk is on the postnatal closure of myelomeningocele and the sort of the surgical tips and tricks that in my experience are relevant, and I'm looking forward to hearing from you and from all the participants, sort of their experience and their advice. So just to start off with, the perspective is that spina bifida is the commonest birth defect involving the central nervous system. And everybody, I'm sure, in this webinar knows the key problem is abnormal closure of the neural tube, and that this is largely preventable. But if you do the job right, though, when these babies are born, it's compatible with an excellent quality of life. And the other really important thing for us as neurosurgeons is that if we get it right early on, that these little guys can have a fantastic quality of life. But it's really important for us to be advocates for these patients and make sure they get all the treatment they need. And another point that I always like making is that when it comes to operating on children, it's really important that you pay attention to clinical assessment, because it's very easy to assume that everything's normal if you haven't examined the kid properly. To be very meticulous about the imaging that you do and recognize that, particularly in small babies, it's about radiation and anesthesia, which have their own risks. And then when you're operating on a newborn baby, to think that they may live for many decades. And you really have to think about that long-term perspective. And then the last thing, I think, for all of us who are pediatric neurosurgeons is to be a bit humble and recognize that the majority of children in the world who undergo neurosurgical operations are not operated on by pediatric neurosurgeons. And we have a responsibility to kind of build the capacity to manage these children by all sorts of different clinical colleagues around the world. Right, so to jump into the topic at hand, so spina bifida or open spinal dysraphism, what we in South Africa call myelomeningocele, is illustrated here. Here's an example of a child with quite a small lesion. But as you can see in this diagram, the lesion on the back is really the tip of the iceberg. And there are a whole bunch of other central nervous system conditions that go with myelomeningocele, most particularly the Chiari malformation. I want to point to some really good educational resources that everybody can access. The ISPN has got some fantastic resources that are available. which can give people some background information. And then there are a number of guidelines that have been published over the years, really pointing to what the appropriate management is of these children. But what I'm going to give you today is very much my sort of personal perspective. So the first thing, as I said, is that this condition is not only preventable, but we in neurosurgery, I think, have an incredible track record now of getting behind advocacy efforts to make sure that the incidence of spina bifida is reduced. And the most important strategy we have is folic acid fortification. And I'm not going to belabor the point. I'm sure everybody in this webinar is familiar with the need to do this. What we all have to take responsibility for is the pretty limited impact that our efforts have had, and probably more than half the world's population at the present time is not yet benefiting from food fortification. So it really is a struggle that we need to continue. The fascinating thing with neural tube defects is that not only do you have an environmental factor like folic acid and a number of other environmental factors, but there's clearly a genetic component as well. And whether these sort of meet through some form of epigenetic dysregulation is speculation at the moment, but it really is a fascinating area of research and an area that I think all of us as neurosurgeons can contribute to. One of the most distressing things that one encounters in clinical practice is when you're counseling a couple that have a pregnancy with a neural tube defect, and they've known about folic acid and they've taken additional folic acid, but nevertheless the pregnancy is still affected. And it's very important to educate people about the fact that not all neural tube defects are preventable with folic acid. But it really does seem that if you have had folic acid before conception, that the severity of the neural tube defect is diminished. So even if you still have a neural tube defect, it's possibly less severe than would have been without folic acid. So if we're going to talk about fetal surgery, it's really important to make the diagnosis. I'm not going to say too much about this because I'm sure Sergio will cover this, but it's really important that we make sure that all pregnant women get access to appropriate antenatal screening. And if a diagnosis is made and fetal surgery is an option, that there is appropriate genetic counseling. Obviously, many families on the diagnosis of a fetal anomaly will opt for termination, but that's not always the case. And I think the important thing is to give non-directive counseling and really support the family in whatever decision they make. I always say to families that there's no right decision. It's really about what's right for them as a family. And then it's our job to support them in whatever decision they do make. So the other interesting thing is the changing philosophies of management. So I trained as a neurosurgeon in the late 80s and early 90s. And at that stage, there was quite a nihilistic approach to spina bifida. And I think the one thing that fetal surgery has done is it has really kind of, I think, reinvigorated the treatment of spina bifida. And even in centers where fetal surgery is not available, I think fetal surgery and the discourse around fetal surgery has led to, I think, a much more engaged approach to spina bifida within neurosurgery as a specialty. But even in centers where fetal surgery is available, it's important to recognize that there are enormous causes of inequity and lack of access to treatment. And it's really important that all of us in our different communities do the best we can to make sure that these babies get the best possible treatment. So every neurosurgeon knows that spina bifida comes in many different shapes and sizes. So this is just a range of clinical images, but they all share this common anatomy of the open neural tube being visible on the dorsum of the child's back. And that's really the key sort of anatomical fact that you need to understand before you operate on these babies. So if the diagnosis is not made antenatally, which is usually the case in our country, and I suspect is usually the case for 80% of babies with spina bifida around the world, the baby is born, it's unexpected. The important thing is that the primary care doctors understand the basic treatment, which is really to attend to ABCs, to resuscitate the baby, and generally they're actually pretty healthy at birth, to then cover the back and refer the baby for appropriate neurosurgical care. And the critical thing is to aim to get closure of the myelomeningocele within 24 to 36 hours, certainly at maximum 72 hours. And the important thing here is to keep the lesion clean. I'm not so sure that antibiotics are really necessary. It's much more important to take care of sort of just basic nursing care, keep the lesion clean, start breastfeeding, and then try to get the back closed as soon as possible. It's important to do an appropriate neurologic examination, and we're all familiar, and every spine surgeon in this webinar is even more familiar with the different motor levels that you would assess in order to try to figure out what the motor level of the baby with the spina bifida is. It's really important to do this carefully before surgery and document exactly what the level of function is when the baby's born. So in terms of the principles of surgery, so these are the principles that I learned from my mentor, Jonathan Peter. And I think, these principles I learned 40 years ago, and I think they're still true today. And there's some very basic things. You want to operate, because you're operating on a small baby, a warm operating theater. It's really helpful to have an assistant. We all know that many times these operations are done by a neurosurgical resident at night on their own, but that's not really ideal. It's much better to do it with two of you, so you can at least sort of discuss what's going on and hopefully do a better operation. Very important to position the patient properly and make sure the abdomen's free. If there's pressure on the abdomen, you're going to have raised venous pressure. And in a small baby, you don't need a lot of venous bleeding in order to get into trouble. So really being meticulous about, sorry, need to try and go back. Being meticulous about these factors is really important. Cleaning the skin, obviously making sure you don't damage the neural placode with your skin prep. I prefer using loupes, but some colleagues like to use a microscope. It is possible to do this oftentimes without any magnification. I definitely don't advocate intraoperative neurophysiology, but there certainly are colleagues that do favor that. I think it's really difficult in a newborn baby to use intraoperative neurophysiology. And then what's most important is to visualize what your closure is going to look like and really plan your surgery anatomically based on what you can visualize. Small baby, gentle tissue handling is going to be rewarded with very quick healing. Be very careful in your use of bipolar, and often you can control bleeding just by compression with the hemostat. You want to aim to close the back in ideally 3 layers, if not more. The most important factor, and I think the single most important part of this talk, is to stress that getting a watertight dural closure is the key part to operation. If you get the dura closed properly, you literally are home and dry, and the baby is going to make a good recovery and have very few post-op complications. You must never ever close the skin under tension, and it's obviously important to make sure in your post-op care that you're giving the baby adequate analgesia. So here's a recent example of a baby with a very small open lesion, as you can see, prone on the operating table, about to have surgery. And 2 of my colleagues, so Tony Fieggen, who works with me at Red Cross, and our current fellow, Jaffet Ngerageza, are operating on myelomeningocele. And I'm going to go through the surgical steps now, just to kind of give you what I think is a very simple 5-step approach to closing myelomeningocele. So I guess the first question is, where do you start? I think a really good principle of surgery in dysraphism is to start from normal. So particularly when you're starting out, I think it's quite helpful to make an incision on the back, just rostral to the myelomeningocele. And then you take that incision down to the bony spine and then work caudally and find the dura and find the myelomeningocele that way. But once you're confident doing these lesions, it's much easier to go straight into the sac and make an incision alongside the neural placode, get straight into the sac and then dissect the sac free. But I think when you're starting off, it's often a lot easier to start with normal anatomy and then work your way to abnormal. So the initial dissection, as I say, if you go straight into the sac, You can either go at the edge of the placode or at the edge of the normal skin. But the goal of this initial dissection is to free the placode from the surrounding skin. And you have to do that without damaging the neural elements. And generally, that's pretty simple and pretty straightforward and not a complicated part of the operation. You then, once you've got the neural placode free, you need to establish whether it's appropriate to neurulate it. It's actually often not necessary, and I don't think that this is an important part of the operation. Sometimes, though, you've got a very bulky placode, and you need to make a decision as to whether you need to debulk the placode. If you're not going to get an adequate dural closure, then it's very important to kind of give some thought to whether you need to debulk the neural placode. But obviously, when you debulk the placode, you run the risk of causing damage to potentially functional spinal cord tissue. So it is a little bit of a judgment call as to what you do at this point. But I don't think neurulation is particularly important, and I don't think it does a lot to reduce the chance of secondary tethering. But it certainly is something that one needs to think about at this stage of the operation. But this really is the key part of the operation, and that's the dural closure. And the key step here is to circumferentially kind of free the dura so that you've got a nice, healthy kind of dural sac that you can then close watertight with non-absorbable sutures. If you get this right, then literally you are home and dry with your operation and the baby is going to do well. Once you've closed the dura, what I always advise our trainees to do is to then ask an anesthetist to give a Valsalva, and that will really kind of give you an indication whether you've got an adequate watertight closure. Sometimes you need to put in 1 or 2 more sutures to make sure you've got a watertight closure. But if at this point you've got a nice dural closure with no CSF leak, then you can feel very satisfied about your operation. And that's what it should look like. So then once you've closed the dura, you then need to figure out how many other layers you can close. If you need to mobilize the skin, you can really just use your fingers when blunt dissection in the subcutaneous tissue plane. And that's, you can often basically get as far as ventrally almost to the umbilicus in mobilizing the skin to get a decent closure. And at this point, you need to figure out how many layers you can close the back. And as I say, you really want to have at least 3 layers, the dura, the subcutaneous tissue, and the skin. But sometimes it's possible to actually close the lumbodorsal fascia. And particularly if you don't have a particularly good dural closure, it's a good idea to close the lumbodorsal fascia as well to reinforce that closure. And then the skin closure, which is really important to not do under tension. If you close the skin under tension, it's just going to break down. And if the dura doesn't leak, well, you might get away with it. But it's really not necessary. Almost always, it is possible to mobilize the skin sufficiently. And I think a really, really important principle here is to try to keep things simple, not get too complicated with fancy plastic surgical flaps. Almost always, you can mobilize the skin sufficiently. And if you're not able to mobilize the skin, making release incisions, paramedian, can then often give you a sufficient skin to actually get the back closed over the dural sac. And then those release incisions will granulate closed. And if you're really confident with your closure, you can then put in absorbable sutures in the skin and hopefully have a very nice cosmetic wound at the end like that. But that's not always possible, and sometimes you need quite a robust nylon or other non-absorbable closure. Okay, so here's some pictures from Dackling Pang, probably the king of dysraphism surgery, illustrating the basic anatomy that I showed right at the outset, freeing the neural placode by making incisions either at the edge of the placode or at the edge of the normal skin, closing the dura, and then closing the skin over that. And as you can see in this illustration over here, there has been an attempt to neurulate the neural tube. But it's a really simple operation. And I think what's most important is to appreciate this anatomy at the outset, understand where the neural tube is, to be able to find the dura and get the dura closed properly, and then it hopefully all falls into place very easily. There are a lot of things that can go wrong, and this is an interesting study published by our colleagues here in South Africa in Durban. And I think many neurosurgeons have had this experience of pretty high rates of CSF leaks and wound breakdown. And this unfortunately is a reality of operating on these babies, particularly when they come too late. And the key thing here is to not give up, to put in a ventricular drain if you need to, if there's an ongoing CSF leak, and treat these babies actively, because oftentimes you can get the back to heal, even if it takes a bit longer, and get the baby home in good neurological condition. For those of us working in countries that have sometimes quite remote healthcare services, oftentimes these babies will only come to a hospital quite late, and sometimes the back will have epithelialized already. I absolutely do not advocate that this is an appropriate form of management, because oftentimes the back gets infected, and then you'll end up with a much worse situation where the lesion is now kind of infected and draining pus, and then it's really, really difficult to actually offer this child any form of active treatment. So it's really important to try to get the babies to be referred early enough to be able to close the back acutely. And as I say, this is not a complicated operation. It's an operation that pretty much every well-trained neurosurgeon should be able to do, and to do well with a good outcome. I'm not going to take too long over the rest of this talk, because I know that Adnan's going to talk about the long-term management, but just important to make sure you nurse the baby properly, ideally prone on an open nappy for the first few days. What you really want to avoid is this situation. You've got stool that has contaminated your dressing, and you don't want to see that, because that's going to mean there's a chance the back's going to get infected. If the baby doesn't have a bulbar palsy, you can start normal feeds, and particularly breastfeeding is really good. Checking for hydrocephalus, and then getting the social workers involved in genetics and counseling the family, particularly with respect to the risk of having another baby with myelomeningocele. There are many things that can go wrong, and Adnan is going to tell us about that. In reality, the most common thing that goes wrong is shunt malfunction, or shunt malfunction, or shunt malfunction, or shunt malfunction, and then occasionally urinary tract infections, Chiari malformations, and things like that. But I think shunt dysfunction is overwhelmingly the commonest thing that trips up the care of these babies in the long term. I'm not going to take too long on this, because I recognize we're running out of time. But just to make the point that although we very seldom operate on Chiari malformations now, it is definitely still required from time to time. And it's particularly important if the baby's got ongoing bulbar dysfunction, to distinguish between an intrinsically abnormal brainstem, which no operation in the world can fix, or Chiari malformation with worsening syringobulbia, which we can fix with a neurosurgical intervention. And this case just illustrates that. And then the final point is that we really have a duty to offer multidisciplinary care. There are many different other specialties that can play a role in managing these kids. And then as they go through adolescence, that notion of transition of care, and making sure that we look after all the things that make adolescence difficult. I really like paying tribute to the work that David McClone and colleagues did in Chicago. I think this made a massive difference worldwide in terms of really helping us as neurosurgeons to recognize that we really have an obligation to give these kids the best possible chance, because more than half of them can have a really good quality of life and do really well if we get it right. So just to end off on hopefully a positive note, it's a common condition, it's preventable, should be diagnosed antenatally. But if it isn't diagnosed antenatally and it's only diagnosed at birth, there's a lot that we can do to make sure that these kids have a good quality of life, and we really need to pay attention to taking care of them properly. Hopefully, I'll see a few of you in Lyon next week at the ISPN meeting, So on that note, thank you very much for the chance to be part of this webinar. Thank you, Mehmet.
Thank you, really. It was a great talk. I think
you.
Krishna can
Yes.
can
Yeah. Good evening from Nepal, sir, to
Yes, hello,
everybody.
sir. How are you
Nice
doing?
meeting you.
Nice to hear your voice
I'm
again.
fine. Yes,
Yeah.
thank you very much. Thank you very much. We can have some question answers. Let me ask the first question to you. Is it okay? Am I audible?
Yes, you certainly are.
Yes, sir.
Yes.
Yeah. So during the dural closure, what is your favorite number? Like 30, 40, 50? Which one? Because one of the factors that prevent CSF leak is the smallest number size of the suture you use.
Yeah.
Which one is your favorite, sir?
So generally we try to use a 6-0. And I
Okay.
think that's you've got very fine, delicate tissues. And I think 6-0
Yeah.
generally works nicely. And at 6-0, you use a 6-0 nylon or proline to close the dura.
So it's all intermittent. It's not a continuous dural suture, is it?
Continuous. I
Continuous.
prefer continuous suture. Yeah.
Okay.
Well,
Thank you very
what is
much.
your experience? I mean, I think that with these fine details of surgical technique,
Yeah.
you know, we all get taught in a particular way, and you get familiar with doing things a certain way. And I know when Dakling Pang does his dysraphism surgery, everything is interrupted sutures, and that's the way many people get taught to do it. But I prefer continuous.
Yeah, I prefer continuous, and I use 50 because 60 is too small to see with a naked eye or even a look. So, but I use continuous too, and reinforce by any intermittent during the Valsalva maneuver if I see any leaks around.
Yeah,
That's the way I
if there's
do
a
it.
leak, then you can reinforce another
Yeah.
suture. Yeah.
Only small. Exactly. Yeah, thank you very much. Are there any questions from any of the participants? Yeah, in the chat there are no questions so far written, so we can get back to you if there are any
Thank you.
questions later on.